Proteinuria evaluation. Normally a person has how much 4 milligram protein per square meter per day, which is equivalent to 0.1 gram per square meter per day. This is physiological proteinuria detected by dipstick as trace or nil type. And if you do this first morning sample PCR, in those cases the PCR will be less than 0.2, in below 2 years, so the level is a little bit higher, 0.5. That is below 2 because of the mature kidney. The child passes some amount of urine, physiological, normal. So it is 0.2, above 2, and below 2 it is 0.5. So, and if you do the 24 hours albumin creatinine ratio, it is less than 30 milligram per gram per day, which is albuminuria criteria, a one stage. Now we know the albuminuria is a sign of the first window of renal damage. So these are the physiological proteinuria. They are found in the normal population, but exaggerated by fever, stress, cold, exercise, and emotion, dehydration, and convulsion. And orthostatic proteinuria is more common than this variety. Policeman standing in the road for a long time can have some amount of physiological proteinuria in the evening. That doesn't mean any renal disease. And pathological proteinuria above this group, more than 4, more than trace is pathological but non-nephrotic. And so, how to define? In dipstick 1 to 2 proteinuria, in subnephrotic it is 3 to 4 plus. So, and the UTP, 24 hours urine collection, it is a little bit cumbersome, but if you can do it, you will get the better picture. And the level 0.1 to 1 gram per square meter per day protein is your pathological bulk, but subnephrotic or non-nephrotic. And your 24 hours PCR 0.2 to 0.2 to 2, and 24 hour ACR albumin creatinine ratio 30 to 300 milligram per gram. So these are the criteria of your pathological proteinuria, and less severe or non-nephrotic or subnephrotic proteinuria. On the extreme, on the other side, the worst side, you have 3 plus, 4 plus proteinuria to define nephrotic syndrome. You have more than 1 gram per square meter, you have more than 2 PCR, you have more than 300 ACR. That define your pathological nephrotic proteinuria. Trace proteinuria means in dipstick 10 to 30, 2 means 30 to 100 milligram per DL, and 3 means 100 to 300, and 4 means 300 to 1000 gram, that is 1 gram, and more than 4 means more than 1 gram per DL. So what are the normal protein that passes in the normal person? It is usually your uromodulin or TAM hospital protein, 85%, and 15% some of the albumin there. So apart from that, you can have low molecular weight proteinuria, tubular proteinuria, like your beta 2 microglobulins and others. When proteinuria is severe, you call it loss of selectivity. That means apart from the low molecular weight protein, you have higher molecular weight proteins like transferrin, albumin, your interferon, and IgG, etc. And when you have lower molecules like albumin and so not gamma globulin, you call it your low selective proteinuria. So loss of selectivity is a sign of the serious renal disease. So and if the proteinuria from the glomerular side and from the tubular side, so thereby glomerular proteinuria will have hematuria, may have hypertension, may have azotemia, may have edema, may have renal impairment, acute, chronic, even ESRD, may have sedimenturia and hypertension, maybe solar presentation. So these are the features of glomerular proteinuria. On the other hand, you may have tubular presentations like polyuria, polydipsia, your growth failure, and in the long term you may have dilated system, a little bit of impaired renal function, etc. So They are the entities like renal tubular acidosis, your Wilson disease, polycystic kidney disease, urinary tract infection, transtubular interstitial nephritis, and drug intoxication, vitamin D intoxication, obstructive uropathy, and so forth. So injury to the renal side, kidney, the tubular side, injury to the glomerular side. Both can be responsible for proteinuria, and at the severe disease, you can have injury to both sides, glomerular and tubular. So glomerular nephritis and your infection related primary, secondary, they are quite common and contributes to the good deal of CKD. In fact, the second largest group of CKD progression comes from this group. And on the other side, as I said, the your acute obstructive infective, they comprise by far the globally the first group of your disease that cause CKD or the SRD needing transplantation. You can also see the proteinuria by turbidometry method. You mix up with the sulfosalinic acid with 1:3 ratio, and no turbidity, you have zero proteinuria. You have slight turbidity 0.01 to your 0.15, and you have 0.15 to 0.3. You have little bit turbid. You can read the paper, you can read the cloud, but you cannot there is no precipitation. You have 0.4 to 1 gram, and when the whole urine is cloudy, you cannot read anything, you cannot say anything. You have how much? More than 1 gram per day, what you call as nephrotic proteinuria. So proteins, why it is important? Proteins are toxic to the renal resident cells. They incite various sorts of inflammatory process, cytokines, chemokines, and organelles injury. Ultimately, inflammation causes fibrosis, and in that way, it causes the loss of nephron, glomerulus, and tubule. As well, and at the end of everything, you may have CKD. Depends upon the time of presentation, rate of presentation.